Assalamu alaikum. Hi everybody. I'm Dr. Fahmi Al. I am very happy and it's my pleasure to be with you today. Thanks Dr. Ahmed Aqal for inviting me and to be part of this activity. So today I will talk about catheter-related bloodstream infection, and my outline will be how to diagnose and how to prevent and how to manage catheter-related bloodstream infection. So let's start by case scenario. So this is a 65-year-old female with end-stage kidney disease on hemodialysis through right internajugular tunnel dialysis catheter. For 6 months, she presented to the ER with fever and chills. Labs showed leukocytosis. There was no discharge at the exit site by examination. Blood culture was drawn and started empirically on vancomycin and ceftazidime for suspected catheter-related bloodstream infection. Later on, blood culture grew MSSA, and the patient changed to cefazolin to complete 4 weeks. So, most of the bloodstream infection in patients on dialysis are caused by infection of the catheter. And this is mainly because the skin flora colonized around the site of the catheter during insertion. Dr. Alon, it showed that the frequency of catheter-related bacteremia is from 2 to 5.5 episodes per 1,000 catheter days at many peripheral dialysis centers. And also it showed that the risk of CRBSI is more associated with non-tunnel dialysis catheter compared to patients with tunnel dialysis catheter. Why is that? Because tunnel dialysis catheter is containing what you call cuff. This cuff is forming a barrier which limits the entering of skin flora along the wall of the catheter. And also, it showed that the incidence of bacteremia in patients with catheter is very high and more in patients with catheter compared to patients with fistula and graft. And it's estimated around 10 times higher in patients with catheter. Also, the patient on hemodialysis with catheter, they are associated with higher risk of infection, hospitalization, and hospital cost compared to patients with AV access by 2 to 3 times. Why we are concerning of CRBSI? Because if untreated well, it can lead to metastatic complications such as osteomyelitis, infective endocarditis, epidural abscess, septic emboli, and septic arthritis. And the incidence of metastatic infection is around 5 to 10% of the patient presented with CRBSI. And this risk of infection, it varies according to the organism. And it's more associated with Staphylococcus aureus, and it's estimated around 10 to 40% of the cases. And the most important risk factor for CRBSI is prolonged use of catheter. This is why we encourage to refer the patient for creation of AV access before initiation of dialysis to avoid the catheter as soon as possible. Other risk factors including history of previous CRBSI, patient with diabetes, patient with iron overload, patient on immunosuppression, and hypoalbuminemia, poor nutritional status, and also recent surgery. So gram-positive organism is the most responsible organism for CRBSI, and Staph aureus with coagulase negatives account for 40 to 80% of the cases. Then gram-negative accounting for 20 to 40%, and the polymicrobial, it's around 10 to 20%. And again, Staphylococcus aureus is the most common associated with significant morbidity and mortality. So how the CRBSI arise. So we have either two sources. Either the bacteria will migrate from the skin along the catheter into the bloodstream, or the bacteria will directly inoculate from the biofilm, which containing the pathogenic microorganism. This is how the biofilm formed. So the bacteria will attach to the catheter surface, and it will grow and divide it. Then it will cause what we call here the ABS production. Then it will form the biofilm along the catheter, and then the bacteria will detach and spread and causing bacteremia. So how they present usually? The most common clinical manifestation is fever and chills during dialysis. However, 5% of the patient, they can present with concomitant exit site infection or tunnel infection. Less commonly, they can present with hemodynamic instability, change in mental status, especially in elderly, dysfunction of the catheter, or other sign of sepsis. So here in this study, they found that 60 to 80% of the patient, they present with fever and chills, 5% they present with exit site tunnel infection, and the others, the rest, and 25% they present what we mentioned before, the septic shock, change in mental status, nausea, vomiting, catheter dysfunction, hypothermia. So I encourage any patient during dialysis feeling unwell, you should rule out catheter-related bloodstream infection. Exit site infection, according to the latest KDIGO guideline definition, is defined as the following. So either erythema, tenderness, or induration less than 2 centimeters from the exit site of the catheter. As you can see here in this picture, this is the catheter exit site. So here the erythema and induration and some discharge within 2 centimeters from the exit site infection. And what about the tunnel infection? It's the same definition, but it's more than 2 centimeters from the exit site. It's along the tunnel. And both they can associated with concomitant bacteremia or virulent discharge. So this is the definition, the updated definition from the KDIGO guideline 2019 is defined as I mentioned before, hyperemia, induration, or tenderness less than 2 centimeters from the exit site, and it can associated with discharge or bacteremia. And again here for the tunnel infection, tenderness, hyperemia, or induration that extend along the subcutaneous tunnel. Also, the patient, it can present with metastatic complication at the first manifestation of CRBSI. So they can present with infective endocarditis, they can present with septic arthritis, osteomyelitis, epidural abscess, or thrombophlebitis. So how to diagnose patient with CRBSI? So the diagnosis is confirmed in 85% of suspected cases, and in 15% of such cases, alternative diagnosis usually diagnosed. So the KDIGO guideline 2019, they updated their definition for CRBSI, and it's defined as the following: clinical manifestation and at least one positive blood culture from peripheral source. So here they include the dialysis circuit. They mention here dialysis circuit or vein. Why they mention the dialysis circuit? Because usually the dialysis patient, they have difficult in venipuncture and difficult to extract the blood culture. So here why they include the dialysis circuit to easily extract blood for blood culture. Let's continue the definition. And no other apparent source, with either positive semi-quantitative which defined as more than 15 colony forming unit per catheter segment, hub, or tip, or quantitative, which defined as more than 100 colony forming unit per catheter segment, for example, hub or tip culture, and it should be the same organism isolated from the catheter segment and from the peripheral source. And also they add here the supportive criteria. So the ratio of the culture of the organism, it should be 3 to 1. So the quantitative of the organism, it's more higher in the catheter compared to the peripheral source, and the differential time to positivity more than 2 hours. So the microbiology, they will call you have positive blood culture from the catheter before the peripheral source. So let's simplify the definition. So you should have clinical manifestation first. Then you have at least one positive culture from 2 sources. From peripheral sources, which is dialysis circuit or vein, and you have positive culture from the catheter with the same organism, and you rule out other causes. So this is again what we mentioned just now, how to confirm the diagnosis by 2 blood culture obtained prior to administration of antibiotic. And very important, we should extract the blood culture before we give the antibiotic to avoid false negative blood culture. And also, don't forget to rule out other causes like pneumonia. If the patient still had urine, you send for urine culture. And now, how to prevent CRBSI? And this is very important because we should avoid CRBSI in patient on dialysis. And the KDOQI guideline, they updated their recommendation. So the most important measure is hand hygiene. Hand hygiene before and after touching the patient. And also, they mention to use the chlorhexidine as skin antiseptic. So to clean the catheter hub when connecting and disconnecting the catheter, and also to cleanse the skin surrounding the catheter exit site. So sometimes maybe you don't have the chlorhexidine. So then you can use the povidone iodine solution with alcohol if chlorhexidine not available. And there is inadequate evidence to demonstrate difference in the catheter-related infection with the transparent film dressing. And also, it's reasonable to use the topical antibiotic or antibiotic barrier at the exit site until the catheter exit site healed. And the key to reduce the infection is to make infection surveillance program, and also to avoid catheter insertion. This is the best way to avoid CRBSI. And also, it's suggested by the KDOQI to use antibiotic lock if the patient high risk for infection, like he had multiple prior CRBSI, and also if the rate of infection is higher in the dialysis center, more than 3.5 per 1,000 days. So either we can use antibiotic, local antibiotic, or also it's recommended to use antimicrobial lock solution. And also it's suggestive to use prophylactic locking with TBA to reduce the risk of catheter dysfunction, which will reduce the incidence of CRBSI. This is when recommended to remove the catheter. So for non-tunneled, it's recommended to keep the catheter for maximum 2 weeks because after that, the risk of infection will be higher. And for tunneled cuffed catheter, it should be removed as soon as possible unless the patient needs it. And for example, this patient has multi-access failure, and this is the only access for the patient, then we keep it for the patient. Otherwise, we should refer the patient for access creation, either AV fistula or AV graft. And also, minimal manipulation of the catheter reduces the infection. So, catheter should be handled only staff, especially for the nurses and for untrained physicians. And this is very important. Every dialysis center should have multidisciplinary team to trace and to make root analysis for any patient with catheter-related infection to know what is the cause and why the patient developed infection. And here also it's recommended by the KDICO, no need for routine culture, surveillance culture to detect any infection. You should send the culture only if the patient develops symptoms or if the patient has a suspicion of catheter-related infection. And also it's recommended by the KDICO to use citrate as a looking solution to decrease the risk of CRBSI and catheter infection. And here, this is about the surveillance program. So as we mentioned before, it's help to study and to know what is the underlying cause for the infection. Is it patient failure? Is it nursing failure? Is it physician failure? And to educate and to prevent the occurrence of infection in the future. Now let's talk how to manage patient with infection, with catheter-related infection. It has two parts, to treat the patient and to manage the catheter. So to treat the patient, we should start empirical antibiotic. And antibiotic should be initiated after obtaining cultures. Then you start the antibiotic to cover gram-positive and gram-negative organism. So to start vancomycin, because there is high prevalence now of MRSA in the community because of unnecessary use of antibiotic. So we should consider vancomycin to cover gram-positive organism, including MRSA. In addition to one of these antibiotics to cover gram-negative, either to start ceftazidime, civibim, carbapenem, piperacillin tazobactam, or aminoglycoside. So every dialysis center and every hospital should have their own protocol for CRBSI based on the result of the culture and the result of resistant organism. So this is from Dr. Aaron, which published in the CA, the Clinical American Journal of Society of Nephrology in 2019. This is suggested protocol for patient with CRBSI. So again, the empirical antibiotic, it should be vancomycin to start with 20 milligram per kg as a loading dose infused over the last hour of hemodialysis, and ceftazidime 1 gram immediately after the dialysis. Then to continue both until you have the cultures. If the patient has allergy from vancomycin or the organism, the blood culture grow vancomycin resistant enterococci, then you start daptomycin. Gentamicin, it's used in some dialysis center because they don't have antibiotics. It can be used, but there is a risk of ototoxicity, and also there is risk of losing the residual kidney function if the patient is still passing urine. So after you have the culture, if it's gram-negative bacteremia, you continue on ceftazidime after dialysis. If it is MSSA, to change the vancomycin to cefazolin immediately after dialysis, and if it is MRSA, to continue vancomycin or daptomycin if the patient with allergy to vancomycin. And also it mentioned here about the catheter lock, we will discuss later on. So here again, what we mentioned, to give vancomycin, and it should be given in the last 60 minutes, and ceftazidime after completing dialysis. However, if the patient unstable in septic shock, don't wait for the blood culture. Start the patient immediately. And at the same time, don't wait for the dialysis session. You can start the antibiotic immediately. So what is antibiotic lock therapy? So it is concentrated antibiotic solution. It's given to the catheter with anticoagulant targeting the biofilm. This is with salvaging the catheter. So antibiotic lock therapy should be given together with the systemic antibiotic. And this protocol should not be given to any patient with indication for immediate catheter removal. So this is how to prepare the antibiotic lock therapy. With vancomycin, 5 mg per ml. We put 1 ml of vancomycin and 0.5 ml of ceftazidime with heparin and lock the catheter with antibiotic. And here, this is the suggested protocol by Dr. Alon, how to prepare antibiotic lock with either vancomycin, ceftazidime, vancomycin alone, ceftazidime, and cefazolin. And usually it's from vancomycin, it's 1 ml, for ceftazidime 0.5 ml, and cefazolin 1 ml with heparin. And the duration of the antibiotic lock usually is 3 weeks for uncomplicated bacteremia and 6 weeks for complicated bacteremia. However, there is no studies comparing the efficacy of lock therapy with exchange of the catheter as initial therapy. And it showed by studies that success rate for lock therapy is around 90 to 100% with gram-negative and around 80% with coagulase negative. And the cure therapy is very low, around 40% with staph aureus. So lock therapy, it should be considered only with patient with gram-negative bacteremia with coagulase negative. So after we obtain the result for the blood culture, then we should modify the antibiotic according to the organism. So if we have MRSA, we keep the patient on vancomycin. If he had allergy, we change it to daptomycin. If the patient has MSSA, we change the antibiotic to cefazolin 2 grams after each dialysis session. And it showed by studies vancomycin increased the risk of mortality in patients with MSSA compared to cefazolin. And if the patient has VRE, vancomycin resistant enterococci, we change to daptomycin. For gram-negative, we continue on ceftazidime if sensitive, or cefepime, or piperacillin tazobactam, or carbapenem, meropenem, ibipenem, based on the sensitivity of the blood culture. And what is the duration for antibiotic? Usually it's 4 weeks for uncomplicated staph aureus, 14 days for gram-negative bacilli, and minimum 14 days from the first negative culture for candidemia. What about if the catheter removed and it was uncomplicated? So the duration of antibiotic will be less. For coagulase, it will be coagulase staph 5 to 7 days. For staph aureus, 14 days. For enterococcus, 7 to 14 days. And for gram-negative, 7 to 14 days. And this is very important. After treating catheter-related infection, you should send for blood culture 1 week after finishing the antibiotic to document the clearance of bacteremia. Because if the patient is still with positive culture, that means they have infection secondary to the biofilm, and which indicate catheter removal. So we finished now the first part, how to manage the patient. Now let's talk how to manage the catheter. So we have two options, either to remove or to keep the catheter. So catheter can be removed and exchanged over the guide wire at the same time, or the catheter should be removed and placed temporary catheter until the patient clearing the bacteremia, then put a new tunnel dialysis catheter after cleaning the bacteremia. So what is the indication for immediate removal of catheter would delay the placement of new catheter? So any patient with hemodynamic unstable, patient with persistent fever after initiation of antibiotic more than 72 hours, patient with persistent bacteremia more than 72 hours after initiation of antibiotic, metastatic complication including the endocarditis, septic arthritis, or stomatitis, infection secondary to resistant organism like Staph aureus, Pseudomonas, fungi, or Mycobacterium, and the presence of tunnel infection. So these 6, it's indicated to remove the catheter as soon as possible and avoid placing of permanent catheter. If the patient needs dialysis, to put temporary catheter or to give the patient 3 days. So guide wire exchange of the catheter, it should be considered with patient with limited vascular access and no alternative access. Also, it should be considered with patient with bleeding tendency or patient decline removal. So the catheter salvage, it should be considered only if the patient don't have any complicated bacteremia and in the setting of gram-negative bacteremia or coagulase negative. So when we retain the catheter, we have 2 options, to use antibiotic lock therapy or just keep the catheter and prolong the duration of the antibiotic. So this is algorithm from the KDOQI guideline, and they started with the definition of CRBSI. Then you should categorize the patient according to the hemodynamic stability. So if the patient hemodynamic unstable, then you should have ABC, stabilize, consider ICU, and remove the catheter. And if the patient is stable, we will follow according to the protocol. So in both sides, we'll send the blood culture from the catheter and from the periphery, either circuit or vein, to send the blood culture before starting the antibiotic, start empirical antibiotic, and to check INR for possible removal. Then, according to the culture result, if negative blood culture, stop all antibiotic. And now, according to the bacteremia, so if the patient document of resolution of bacteremia and fever, which indicate responding to antibiotic after 2 to 3 days, then we'll modify the antibiotic according to the culture. So if the patient grow coagulase negative staph or gram-negative bacilli, we'll change the antibiotic according to the sensitivity, and we'll continue the antibiotic for 14 days, and we can consider exchange of the catheter over the wire just because of the biofilm. For Staph aureus, we should remove the catheter, antibiotic for 4 weeks, and to consider transesophageal echo to look for metastatic complication. For candidemia, we should remove the catheter, antifungal for 14 days, and to look for metastatic infection, and to consider the guide wire exchange only if the patient has limited access. And if the patient has persistent bacteremia and persistent fever, we should look for metastatic complication, so catheter should be removed, and antibiotic or antifungal should be continued for at least 4 to 6 weeks, and to do the workup for metastatic infection. So we finished the part related to the bacteremia, and now we'll talk about how to manage exit site infection, and it's common. So as per definition, we mentioned before, it should be less than 2 centimeters from the exit site. So if there is any purulent or pus discharge, we should send for culture before initiation antibiotic. And if there is any symptom concerning for bacteremia, we should send blood culture. So because of skin flora, here the antibiotic will be directed toward the gram-positive organism, and then will modify according to the culture result. And the duration of antibiotic usually from 7 to 14 days. And usually patients with exit site then don't require removal of the catheter unless they are not responding to the therapy or they have concomitant bacteremia. And what about tunnel infection? Same, we'll send culture if there is any drainage, and also we'll consider sending blood culture if a patient has systemic symptom. And here the antibiotic, it should cover gram-positive and gram-negative. And then it will be modified according to the culture result. And the duration, usually it's 10 to 14 days in absence of bacteremia. If bacteremia there, then we should manage the patient as bacteremia and we should remove the catheter. And also we should consider catheter exchange with new subcutaneous tunnel if the tunnel infection not responding to the antibiotic. If not possible, then it should be removed and to place the catheter at new entry site. And by this, I finish my lecture and waiting for any question from your side. Thank you.